All right. Good evening, everyone. Thank you so much for coming. I think we waited a couple more minutes for some more people, so we'll start. So for those of you who don't know me, my name is Edan Shapiro. I've been at Georgia Urology now for about 8 years. Before coming down to Atlanta, I did my training at Columbia University in New York City. And I practice general urology, but one of my special interests is in avoiding dysfunction. And what that means is, in this case, for men or also for women who have difficulties with the normal urination process. And one of my focuses is on different minimally invasive treatment options for men with enlarged prostate. So the title of tonight's talk is about the enlarged prostate, as it said above. And these are the things that we're going to be talking about tonight. So the first one is, what is BPH, which I will also refer to sometimes as BPE, which is benign prostate enlargement. The next, we'll talk about how this is diagnosed. And then finally, we're going to talk about different treatment options. And the goal for this evening is to see all of the different treatment options, but I want to specifically focus on some of the newer procedures which you may not have seen before. So let's start from the very beginning. What is the prostate? We're talking about an enlarged prostate. It's obviously important to first know what we're talking about. So it is a small gland that sits in the pelvis. It's really a reproductive organ. So it's the prostate produces the fluid that basically helps transport sperm during ejaculation. And it sits right under the bladder. And the main reason it's important to you is that it grows with age. So around 50 years old, on average, the prostate begins to grow. And it's a process that with age, it continues to grow. And it's important to differentiate some of the different conditions that can affect the prostate. And I have here 3 of them. And I want to just mention that tonight, we will be only focusing on the middle one. I often hear from patients that they believe having an enlarged prostate may increase their risk of having prostate cancer or something else. And this, in fact, is not true. And it's important to mention that each condition affects it differently. And having one of these 3 by no means necessarily predisposes you or indicates that you might have any of the other ones. So again, BPH, which stands, it's an acronym for benign prostatic hyperplasia. I'm going to use it interchangeably with one of the newer definitions, which is BPE, which is benign prostate enlargement. And that's really just the clinical term for an enlarged prostate. As mentioned in the previous slide, this is a non-cancerous enlargement, and having an enlarged prostate by no means indicates any risk, higher or lower, for prostate cancer. So as we can see from this graphic, it typically grows with age. With each decade of life, more and more men. So by age 60, we see here 70% of men. And we can see by age 80, 90% of all men are already having symptoms of an enlarged prostate. As mentioned before, this is usually a progressive disease. The top is a cartoon showing a normal prostate on the top left. And as it enlarges, you can see both that the prostate gets larger, but the other thing that it's showing both on the top and the bottom, that this growth starts to impinge on the urethra. The urethra is the tube that goes from the bladder out through the penis. Is where the urine goes. So as this prostate gets bigger, it starts to compress on that. And this can often cause urinary problems. And as we see here, what I was just trying to demonstrate is that the prostate gets bigger, the urethra gets smaller. Another thing to point out on this graphic, if you can see on your screen, if you have a large enough screen, is that the bladders look different. So if you notice the bladder on the bottom left, what you see is a bladder that looks regular and smooth. What you see on the bottom right is not just that the prostate gets bigger, but the bladder starts to change. You have what's called a hypertrophy, which basically means the bladder muscle is getting stronger because it has to compensate for the enlarged prostate. So it has to squeeze with more and more force. That's not a good muscle to get stronger. Like the heart, when this muscle is getting overworked, it can start to deteriorate over time. And in general, also the size of the prostate does not always correlate with the severity of the symptoms. So this kind of shows what I was just talking about, which is that if you have an enlarged prostate, and if that results in the bladder having physical changes to the muscle, if you don't do something about it in an appropriate time, it can, not that it does, but it can result in some irreversible damage if it's left untreated. And this is just a statistic I have. Close to 90% of men who go on watchful waiting, which basically means do nothing and say, you know, I'm bothered. I might wake up 1 time, 2 times, but I don't like taking medicine. I don't like doing anything. I'll just wait. It doesn't mean that those symptoms are going to also wait for you to decide. And sometimes things may deteriorate. And the goal is basically to intervene before it's too late. So I put on the bottom of this slide here is that not treating a prostate can lead to deterioration. That's a take-home point. So if not treating a prostate may lead to irreversible damage, I think it stands to reason that the flip side of that is also true, that surgery, and whatever, we'll define surgery later, but some sort of intervention, it should say, so some sort of procedure that will open up the prostate will result in disc obstruction, which may ultimately prevent loss. This is an interesting thing that I've started to include in these talks that I give, and I think it's very interesting. This is from data from men who actually have their prostates removed. So imagine a man in their 50s or 60s who has prostate cancer, and they surgically remove the prostate. Now, you would assume that if the symptoms from the enlarged prostate were would now potentially completely resolve because the prostate is physically gone and it's removed surgically. However, we see that only, let's make it simple, 2/3 of men, so about 1/3 of men continue to have symptoms even after their prostate is removed. And the hypothesis or the speculation here is that even though the cause of the deterioration has been removed from the body, the damage and the impact might be everlasting. So we talked about the prostate and enlarged prostate, and now let's talk about some of the symptoms. And you see these popping up on your screen, and maybe many of these are resonating with you as you're listening to this. An urge to urinate, frequency to urinate, the stream might be weak, it might take a while to start it might dribble at the end. And these are typical symptoms of enlarged prostate. Now, if you're not necessarily thinking that these bother you, just keep in mind that although they may not be bothering you, they may be bothering someone that you live with. What this cartoon is showing is that while maybe only 10% of men say that waking up bothers them, 65% of the women in this case who are living with those men are impacted, their sleep is impacted by the constant waking up and going to the bathroom. So I think it's just important that it may be you that's impacted, and that's what we're talking tonight for you and helping your symptoms, but there are also sort of secondary victims, if you will, to the enlarged prostate. It should be to no one's surprise that enlarged prostate, or hopefully it's no one's surprise that enlarged prostate is the top reason by far of reason that men may end up visiting the urologist. And as mentioned with sleep as an example, but just in general, men who don't have the symptoms treated, whether it's with medication or a procedure, can have a reduction in their quality of life. I had a gentleman today who I saw in the office who is telling me that whenever he travels, he needs to make sure that he is always sitting in the aisle. And that just impacts him. Now, that's not the biggest deal in the world, but I bring it up to illustrate that it's the little changes in the day-to-day life. If you're not able to go to the bathroom, if you make sure that every time you go to a store for shopping or go to a movie that you're aware of every bathroom and know where everything is, that can be a major disruptor in life. And again, unfortunately, nearly half of men who have symptoms that are severe enough do have lifestyle changes. So we talked about the symptoms. Now let's talk about how this is diagnosed. So one way is from a medical exam, so history and I should say an exam. I mentioned here a bladder scan. These don't always need to be done. Often history itself and alone is sufficient, but sometimes there will be an exam. So when we do a rectal exam, the primary purpose of that is really for prostate cancer screening, but it can also give us an approximation of the size of the prostate. But part of the exam, if you will, is a questionnaire, which if you've been to our office, you should be getting this every single visit. And this is called the AUA, which is the American Urologic Association Symptom Score. It's also called the IPSS, the International Prostate Symptom Score. And that really talks about these symptoms that we've talked about. These are the 7 questions. It's made up of 7 questions. Each question is on a scale of 0 to 5. So 0 would be the lowest score, which would mean you absolutely have no symptoms. And 35 would be the highest score. If you have every single one of these 100% of the time, you would have a 35. But in addition to the actual score, we also always ask how the quality of life. You can have an individual who may have a high score whose quality of life is basically unaffected and they're happy. You can have a man whose only symptom is waking up 2 times at night, but that really impacts his life in such a negative way that he would say he's very unhappy with the symptoms. And I do believe that each of you were sent an electronic copy of this. And if not, we will make sure to send an electronic copy with a link at the end of the talk to all of the attendees. So here are some other optional studies in addition to having a questionnaire. Oftentimes we'll do a study to actually get a quantifiable flow rate, which means you could say, well, my flow is weaker than it used to be, weaker than what I remember as a kid, but sometimes it's important to actually put a number. How fast or how slow is it going? Another thing that's very commonly used for men, especially after they try medication, if it's not working, and this is in our updated standard guidelines in national urology conferences, is to do some sort of pressure flow study. And this is a way to determine how the bladder is working. That's the pressure part. The flow is how fast or slow it's coming out, what the pattern is. But we need to know both of those. And I'll show you in the next slide why that's important. Sometimes we'll do an ultrasound, either a transrectal or an abdominal ultrasound to get a more, I would say, reliable and a more precise measurement of the prostate as opposed to just with the rectal. And sometimes we'll look in with a camera in the office just to see where the growth is and make sure nothing else is going on that may be unexpected. So this is an example, probably the most common way we do pressure flow studies in our office. This is a non-invasive test called a Eurocuff. And what this test does is it asks you simply to come in with a full bladder, and you go in a room and there's this device which basically fits over the penis. And all you do is just urinate as you would normally. So nothing goes inside the body. And when you urinate, this device is able to determine not only the flow, how fast it's coming out, but it's also able to determine the pressure in the bladder. And why that's important is for 2 reasons. Number one is if you are considering having a procedure, we want to make sure that although you might have weak flow, we want to make sure that the bladder is still having good life and can squeeze hard, so that if we open things up, things will get better. Number two is that we want to know that if you choose to do nothing or do medication, we want to make sure that we are not having loss of function. So you might have on this picture, if you start on the bottom right in the unobstructed zone, which is a high flow rate and a weak or normal pressure of the bladder, you might have over time the bladder squeezing harder and harder and harder to allow you to continue to have the exact same flow come out, even though it's putting more stress on the bladder. And that would give us a sign to say, maybe it's not so good to wait. Maybe we should start considering doing something. So now let's move on to treatment. So if I were to design, if someone said, Dr. Shapiro, I want you to design the ideal treatment, here are things that I would want. So obviously, I'd want to improve the symptoms. That goes without saying. I ideally would like to have a procedure which did not have any impact on sexual function. I would like to make it as easy and painless for the patient. I would like the recovery to be quick. I want it clearly to be safe and durable. And that's, I think these are self-evident, but it's important to sort of lay these out as we approach the different treatment options, because we're going to potentially judge option A versus option B versus option C with these sorts of goals in mind. Now, if we talk about prioritizing goals, this is from a recent patient survey, and these things are exactly the same, right? The most common, interestingly, was not needing a catheter, but the other ones are ones that we talked about: rapid relief, rapid recovery, minimal downtime, the things that a man is going to want in having a minimally invasive procedure. So, like everything in life, there's a spectrum and there's a gamut of options, and it goes all the way from the left of the screen, which is watchful waiting, which is doing nothing, all the way to surgeries, and everything in between. And we're going to look at all of them. But before we look at them, one thing that people don't realize is only 2% of all of the patients who are having enlarged prostate end up getting some sort of intervention, which basically means you have, let's say, call it in this situation, 13-14 million men versus 250,000 men who are doing nothing. Now, if you were to tell me that 30% of men who did nothing were fine and 65% of men who are on medication were fine, then I would be thrilled. That would be great. But we know that not to be true. We know that often people just give up hope. They assume the pills aren't working. The only option is to go to the hospital and have a major surgery, and they may not even come back to the office. So I think one of the goals of mine for tonight and in general in talking to my patients is to make sure that if you choose to do nothing, that's always an appropriate choice, provided that you know the options and provided that you are aware of the pros and cons of all of them. So let's try to understand why people don't often go. So in the 40s and 50s, we had the TURP, which is a traditional roto-rooter. In the 90s, we started having more oral medications. And then in the late 90s, we started having laser fibers and different tools of vaporization. People were doing microwave, people were doing TUNAs, which is needle ablation of the prostate. That's what the NA stands for. But since that time, until recently, I would say there has not been that much stuff. And this is a slide I borrowed from a colleague, so it's not my own, but using it with his permission, I want to kind of graph different things if you look at the benefit versus the risk. So if you start with medications, clearly almost no risk, and also, maybe low benefit. The other option is what's called an open prostatectomy, which is a surgical procedure that's done for benign growth, where we go in and sort of core out the entire inside of the prostate. And that is maybe extremely beneficial, but also has higher risk. And what you see is that I also put TURP and PVP, which we'll talk about. This is the laser ablation. These have lower risk, also good benefit, but you still have basically this entire gap in the middle. And that really leaves a space for MIST. MIST stands for, as it says on the slide, minimally invasive surgical treatments. As I mentioned before, of the 13+ million men with enlarged prostate, 2% choose one of these. This is just kind of talking conceptually that when you talk about opening the prostate or unbulking the prostate, it really just comes down to plumbing. There's different ways to do it. You can physically remove the tissue, you can injure or ablate the tissue, or you can just mechanically open it without injuring it or removing tissue. So going back to our wish list, I just want to add one more as we're looking, and that last thing is an option which ideally allows us to do it in an office setting, which would be tolerable under local anesthesia. Local anesthesia may be, just straight up lidocaine, or maybe with gas, not anesthesia, but the gas that you get when you go for a dental cleaning. So something that requires no driver, no downtime. You can get the procedure, and 5 minutes later, you can get in your car and drive home safely. So now let's go back to talking about some of the different treatment options, and to say that different options are appropriate for different patients. There is not a one size fits all. It's important to find what's good for you. So the first one is watchful waiting. Obviously, there's no surgery. It's free by definition, but the risk, if you want to call it a risk, is that your symptoms will worsen and you may have deterioration of the bladder. So moving on to medications, these are things like Flomax or tamsulosin. Again, no surgery. These are not free, but they're often completely covered. And that's an advantage. But a disadvantage is that these are pills which need to be taken daily. And although they are very well tolerated, they are not without their own set of side effects, whether that's ejaculation side effects, whether that's feeling fatigue or feeling dizzy, nasal congestion. And over time, they may stop working. In fact, we know that 3/4 of men who choose medication do this despite the fact that they only provide modest effect and that they have some unwanted side effects. And in terms of the discontinuation, we know ultimately that about 1/3 of men are only satisfied with their effectiveness. So the majority of people want something else. In terms of compliance, we see 29% compliance at 1 year, which is interesting because these are similar for a lot of these chronic medications. It's not cancer, but this could affect day-to-day life. And if 70% of men have stopped taking their medication at the 1 year mark, that obviously means that we need to do something else, whether it's education or intervention. And this is a quote that I put up here. I'll just read this out loud. This is from a recent guideline statement from the American Urologic Association, is that since many men discontinue medical therapy, yet proportionally few seek surgery, there is a large clinical need for an effective treatment that is less invasive than surgery. And that's, I think, the lens that I want to do the remainder of the talk through. So now let's move on to some of the lesser known options. And the first one we'll talk about is the prostatic urethral lift, also known as the UroLift. This is almost always done as an in-office procedure. There is no effect on erections or ejaculation. It's a very rapid return to work, so very minimal downtime. Typically, there's no catheter, or if there is a catheter, then we do that usually with a removal the next day. Like any intervention, no matter how non or minimally invasive it is, there are some disadvantages. And I mentioned here, there could be just some discomfort, maybe some blood in the urine, and short term, there may be some increased urgency. Sometimes people come in a week later and say, gosh, my flow is much better, but I'm going all the time and I'm going at night. And I tell them that's expected. that may get better. Your bladder, your prostate, they're sort of re-equilibrating, recalibrating, getting to know each other. The bladder doesn't have to squeeze as hard, things are open, and that usually gets better. So by the 4 or 6 week mark, all of that should be done. In terms of how it actually works, this would be an example of not removing tissue, not actually heating or injuring tissue, but just mechanically opening up. So this is done through a cystoscopy, which is a camera. So it's done under vision. And the graphic here is showing that you're going in, and the example I use is kind of like stapling open the prostate. So you're going in with the scope, you're using the scope to push over the tissue to the side, and then you put the device, which is basically a suture, a permanent suture material that goes in, and then you adjust the strength of that and the length of that suture so that when you remove the scope, it keeps it compressed. Typically 4 implants are delivered, but it could be more. Sometimes it's 6, sometimes it's less. It really depends on the size of the prostate and the length of the prostate. So this is obviously, an ideals picture, but this is a before and after view from the urologist camera. So on the left side, what you're looking at here is your scope is within the prostate channel, and what you should be seeing behind in the prostate is the open bladder. On the right side, you can see that after you open up the prostate, suddenly you can see the channel. So that black sort of abyss in the background, that's actually the bladder. And now if the bladder is squeezing, all of a sudden there's an opening, an open channel for the urine to come out. So as mentioned, may not require a catheter. I would say the majority get a catheter for a day. Light blood, all normal. Short-term pain, very quick return. If you want to go back to work the next day, you're not going to hurt yourself. If you're up to it, that's fine. And as mentioned before, although there's that short-term urgency and frequency, as early as 2 weeks, up to 3 months, you'll continue to have improvement. And usually the 3-month mark is a pretty good idea of where you'll be long-term. We know that the durability has been proven through 5 years, which is often important. So the expectation is not that we do this and it lasts 6 months. We want it to be a medium to long-term option. I think I can talk and talk and talk, but a video really does much better justice. And I'm going to show you a video of this procedure. That's going to be.
The UroLift system is a proven minimally invasive technology designed to relieve urinary symptoms and improve quality of life with minimal side effects for men with an enlarged prostate caused by benign prostatic hyperplasia, or BPH. The UroLift system procedure begins by inserting an implant delivery device into the urethra. An attached endoscope provides visibility to the obstructive prostate. On reaching the area blocked by the enlarged prostate, the obstructive prostate tissue is moved aside. Following a trigger press, the device inserts a fine 19-gauge hollow needle across the prostate and deploys the implant through the needle. The implant is a nylon suture fixed in place with a thin metal tab at each end. Depending on the prostate size and blockage severity, the doctor inserts several more implants the same way. Typically, 4 to 6 implants are placed into the prostate. The outer capsule of the prostate is firm and provides a solid anchor, which allows the implants to lift and hold the enlarged prostate tissue out of the way so it no longer blocks the urethra. As the sutures are shorter than the prostate depth, the prostate laterally compresses. This reduces pressure on the urethra and provides immediate visible results so urine can flow freely. It's a mechanical solution to a mechanical problem. The minimally invasive procedure requires no cutting, heating, or tissue removal. This procedure avoids erectile and ejaculatory dysfunction. It typically also means minimal downtime, mild to moderate side effects, and a quick return to normal activity. The UroLift system provides a clinically proven treatment for those who suffer from an enlarged prostate that can get men off BPH medications and avoid major surgery.
Okay. So before, I'm not going to play the video again, but one of the things that I realized I forgot to mention at the beginning, I apologize, is at the end of this, this webinar, I will open it up to questions. I'm happy to stay as long as anyone wants to stay and answer questions. On the bottom of your Zoom screen, there is a box that says Q&A, and hopefully if you click, you can ask a question. These are anonymous, so your name will not be seen, and I'll address it. Obviously, if it's appropriate question, I will address it at the end. So hopefully we have time, and again, sorry for not mentioning that. Hopefully, if you had questions, you still remember them and can put it in the Q&A. All right, moving on. So this is pooled data. This is called the LIFT trial, and what I want to show here, and it's a busy slide for sure, but what I want to show is the top line is the AUA symptom score. So what we see is that you have an average about a 10 points. So on average, these patients started in the 20s and go down to the teens. So that happens rapidly. You see the quality of life, which is higher number means more bothered gets better, and Qmax, which means the flow rate, the higher number is a quicker flow of urine, that goes up. So if you just look at this graph, and this is by years, you see not only does it happen rapidly, but that it's durable. You don't really see it drop and then go back up. You see it drop and then stay that way. And I also want to just mention that this is not a new procedure. There have been over 400,000 UroLifts done worldwide to date. This is something hot off the press. This was just presented literally about a month ago in Chicago at the National Urology Association meeting. And this really confirms what I just showed. This was a controlled study of over 300 patients, and it has a low retreatment rate at 5 years, which is similar to what the LIFT study showed. And the other take-home point, and this is hopefully resonating with you with what we talked about with bladder deterioration, is that earlier is better. So if you're going to do a procedure that's minimally invasive, it is more beneficial to do it at an earlier stage rather than waiting until the bladder has lost some of its ability to squeeze. So now moving on to the next one, which are heat-based therapies. These are often done in office procedure. Often, I wrote oral sedative, but these can often be done alone with the nitrous gas, which we offer, at least in the Fayetteville office. Again, fewer side effects than surgery. Sometimes has sexual side effects, less so than some of the surgical procedures, but definitely can have sexual side effects. Definitely longer use for a catheter. I do a lot of these as well, and I tell patients, just be aware you may have a catheter on the front side for 5 days or so, and it may be several weeks of discomfort at front. And sometimes this is right patient. This is right for someone if they are saying, well, as long as by the 6 or 8 week mark, I get to the same point, I'd rather do what makes more sense long-term than short-term. So I don't want to scare anyone away, but this is just sort of a different way of thinking about it in terms of what your initial side effect profile is going to be and how long until you are going to expect results. So this is how it works. The way it works is going in with a camera, and instead of mechanically opening it or scraping it out, steam would be injected, in this case, into the prostate tissue through a needle. And what happens over time is that steam, which is basically cooking the prostate, heating the prostate, injuring and destroying the prostate, those prostate cells ultimately die. And as they die, that prostate tissue starts to regress. And as it regresses, the prostate hopefully opens up. So you get the same desired end result of an open channel. In terms of after this procedure, again, 5 days is typical for a catheter. And you may have painful urination again for a couple of weeks following it. This is interesting. This was presented, I believe, last year. This is claims data, and there are a lot of issues with claims data, but what this means is it's looking at a real world environment. So it's looking both at Medicare patients and commercial patients. This is looking at over 200,000 patients. So it's a very large subset of patients who were getting either medical therapy or a green light, which here is in the blue, which is PVP, a PUL, which is prostatic urethral lift, which is the UroLift, or a TURP. And one take-home point is that the UroLift, which is done in the office setting, has comparable retreatment rates. So lower is better, comparable retreatment rates to sort of the gold standard hospital Roto-Rooter procedures. And that's, I think, important. So overall, if you look at the complication rates, it's low, and it's lowest for UroLift, which is not that surprising because there's no heat, there's no energy, you're doing it in the office, but also that the retreatment rate is comparable, which is also important. And that's also, if you look at real world return procedure rate, the UroLift is low, is 17%, and that's almost identical to what I quoted before with the updated data that just was presented last month. So this has been studied, and low complications, good success, things you want to see in a procedure. Next, we have water vapor therapy. This is an example of this would be called the aquablation technique. This is a procedure which is comparable. I would look at it like a pressure washer. So there is no heat, but you are certainly destroying tissue. This needs to be done in a hospital setting. This needs to be done under general anesthesia. Patients are either going home the same day, but more typically staying overnight to make sure that there's the bleeding is controlled. But this is using water pressure to open up the channel also through destruction of tissue. As you move to major surgery, and I want to just clarify, and I should say to qualify that major does not mean that we're making an incision, does not mean that you are going to be in a hospital and that you're going to have a major recovery. It just means that you're doing something in the hospital under general anesthesia. That's why major. So the advantage here is that it really does maximize the flow and the symptom relief. You remove prostate tissue, you have low treatment rates, it's durable, time and tested. These have been around for decades, and they remain to this day really to be the gold standard. But it does require hospitalizations. You generally have a catheter for several days. There's some restricted activity afterwards to limit and try to minimize having bleeding as a complication. And when you talk about sexual function, although a small percentage may actually have erectile issues, you should go in assuming that you will have ejaculatory issues. Ejaculatory issue means retrograde ejaculation. So you will still have a normal sexual response, but nothing may come out. Now, for many men, if they're not planning on having more children, that's not a big deal, but it's important that they know that in choosing. So this is how a TURP or a laser works. So here is a TURP. This is also a scope, but as opposed to a scope where a needle goes in or a prostate staple device goes in, which is the UroLift, or even the aquablation, here it's almost like an electric ice cream scooper that uses an electric current to scrape away the tissue on the inside of the prostate. A laser procedure works similarly, but instead of using energy to scoop it out, you use a laser to heat the tissue and vaporize the tissue. So the advantage of a laser procedure as compared to a TURP procedure is that you ultimately here will create that wide channel, but the risk of bleeding is less. These patients go home the same day, and that is extremely advantageous. So certainly, whereas people who needed these procedures were always getting the TURP procedure, I would say the pendulum has completely shifted, that the vast majority of patients are getting the laser procedure for the benefits that I just mentioned, which is that you can go home the same day, and the results are identical to the TURP. So with that, I want to just conclude. And what I want to say is that there obviously is continuing innovation, but this innovation in surgical procedures allows us as the urologist to treat the symptoms in a varied way, but hopefully with safe options that give you rapid functional recovery. And minimally invasive options do exist. They exist for both removing obstructing tissue, that's the green light, or the TURP, or the aquablation. You can vaporize the tissue, or you can simply tether it out of the way and give you the opening. So it's important to pay attention to your symptoms, and that helps you determine when you need to do something, and it helps us determine what that thing should be. So again, each solution has its own risks, benefits, and costs, and it's important to find the right solution for you. And that really is the take-home point. So for that, we are going to open to questions. As I review those questions, I wanted to show this slide and sort of talk out what the next steps are. So there are several different options to make an appointment. And the reason I want to sort of talk this out, so hopefully this you bear with me, is that people often complain about not being able to get into the doctor, especially not able to get into the specialist. And I want to be sensitive of that. And if you gave your time and you are motivated and you listen to this webinar and you want to get in, I want to tell you that there is an easy way to basically get an immediate appointment. And the way to do that is by going in and scanning this QR code. So if you take your phone and you literally take your phone and hold it up to that QR code, you'll get a yellow link, and that link will take you directly to our self-scheduling site. You can also do it through the website, which is also here at gaurology.com, and you can go to schedule an appointment. If you go to my landing page, Dr. Shapiro, Edan Shapiro, you will go and you will select as a visit type, it will be called webinar event. If you do webinar event, you will have access to special proprietary slots, which are open only to patients who have gone to a webinar. So there are 5 slots a week, and these are slots which are not available to other patients. So if you look at my schedule, and let's just for hypothetically say that the next 3 weeks, there are no new patient slots available. If you do webinar slot, you might be able to get an appointment as early as this coming Monday. I also want to say that if you go to the UroLift.com website, they have a physician finder. So many of you may be patients of Georgia Urology. Many of you may be, not patients of Georgia Urology, or maybe you're patients of Georgia Urology, but not in a location that I treat, which is in Fayette County. So this is just a place to find someone who is doing the UroLift procedure. And you can also sort by people who are what's called Center of Excellence, or COE designation, which means they've done patient education, they've done a certain number of cases, they've proven that they have reproducible and good results. So that's the ideal way to do. And I have a bigger version of that QR code, which I'm going to put up now, and that's there. So hopefully that helps. I'm just going to open up. Okay, so I'm going to start just going through the questions. These are great questions. So the first question is, this is, what happens after the procedure? Does the prostate continue to grow? And the answer is it does continue to grow. So if you had a procedure, whether it's a UroLift or a TURP surgery, anything where you're not actually removing the entire prostate, which is only done in the setting of cancer, the prostate continues to grow. So the most common reason of why you might need a retreatment would be regrowth of the prostate or incompletely treated prostate initially. The other thing to consider, though, is sometimes after having a procedure, the body can heal where you get a scar, which is called a stricture, and that might be why you're having it. So what your urologist should do, and usually will do, is go in with a camera and look and see what's going on visually. Is there a scar that's formed which needs to be opened and stretched, or is it just mechanical regrowth of tissue? The next question is, this is metal, it's titanium, which I mentioned. Is it MRI compatible? And the answer is yes. You should be able to have a full body MRI scan without a problem. Another question, again, love these questions. Will I set off a metal detector at the airport? When you have this procedure, if you have this procedure, you will get a card which says that you have a medical device, just so you can carry it with you. But even though patients sometimes are excited to see the metal detector get set off, or even the one where you now scan where you're standing up there and it goes around you, it doesn't happen. So although that might be presumed, this doesn't happen. Someone asked about this webinar. We have similar recorded webinars on the Georgia Urology website, which are for patient education. It's sort of our educational library. Someone asked if this is different than a stent. So stents are interesting. When people think of stents, obviously the most common things that we think about are stents that go in the heart. And the reason that stents in the urinary system are very different from stents in the vascular system is that people can get kidney stones, and people get kidney stones because there are crystals that are in the urine that can stick to the inside of the kidney, and as you get a stone, it can get bigger and bigger. And that same thing happens whenever there's a foreign object in the urinary system. So for example, if a patient has a catheter in place, we change these catheters usually every 3 to 4 weeks for this purpose. If you leave it in longer, it starts to get encrustations on it, and stones like barnacles almost form on it. Same thing for a stent in the ureter after a stone procedure that can't be in indefinitely. And the same thing for a stent in the prostate. There used to be stents. There are new stents that are trying to get around this by having, they elute certain medications. But the concern is that you get encrustations and then it becomes challenging to remove, and it may cause more issues than good. There are newer ones that are coming out. There have not been any that have been FDA approved, which have really come to the forefront, which are first-line treatments. But I think that the jury is still out on whether or not that stents may be used again, I should say, in the future. Someone mentioned they had a UroLift 3 years ago. The flow became weak over the past year. What do you recommend? So in this situation, I would recommend, just like the person who asked who had a TURP 12 years ago, is to come in and get a better sense of what the symptoms are. If the symptoms are simply somewhat of a weaker flow, but it's not bothering you, option one is you could do nothing. If you're asking the question because your quality of life is becoming more and more impacted, we can try medications again, like Flomax, and see if opening things up helps. If it does, that at least tells us it's a prostate. And we can look inside and we can do a urocuff, and we can say, is it that the prostate is just continuing to grow and the UroLift force of holding things open is no longer sufficient to do it, and in which case we could do something else, or is there a different process taking place? The other thing to keep in mind is what often happens, and this would not be a 3-year situation, but what often can happen is that if you think about the immediate post-operative period, you have a bladder which is squeezing at a very, very high pressure. So the pressure is way up. You've got a prostate which is enlarged. You open the prostate, the bladder pressure gives you a very robust flow. But that's almost artificial because the bladder, you don't want the bladder to squeeze that hard. Part of the reason of doing a procedure is to take the stress off the bladder. So it may just be that the bladder is now squeezing at a normal, safe pressure, and you are now seeing that as a weak flow. But if you're saying your flow is weak, I would say go to the office, get an actual number, you take a Eurocuff and say, is the number lower as an actual objective value than it should be? And if so, that may mean that we need to do something else. If it's not, then we can let it ride just depending on what your symptoms are. Those were all of the questions that I saw. Let me just see if the other moderator had any other questions. And if not, okay, so that's the end. Again, I appreciate your time. I know we started a few minutes late, so I appreciate your patience. Hopefully this was educational, whether it applies to you or to a loved one, whether or not you've had a UroLift, whether you're interested in a UroLift or one of the other procedures. Hopefully you leave tonight's talk with a much better grasp of how things work, what's going on with the prostate, and what the options are, both past, present, and even get a sense of what the future may be. So thank you, and I'm going to end the show.